Joining me for this series on urinary system pathology. This video is going to cover renal infections. And there are a handful of renal infections that we are going to discuss. These are going to be probably more related to like urinary tract infections, things that can travel back up through the bladder, through the ureters, and back into the kidneys. The first infection that we're going to discuss is pyonephrosis. Pyo stands for pus, so this is a bacteria, a pus that is collecting in the renal system. Usually caused by bacteria, it can cause severe urosepsis, so that means just like an overload of bacteria within the urology of the renal system. This is an emergency. If somebody has pyonephrosis, they need to get to the hospital to have some sort of antibiotics administered, typically by IV, or they need to have a drain put in to get that pus out of there. The kidney will not function appropriately if it has this ongoing infection going on. This can be secondary to obstruction. So if a person originally had a history of hydro, maybe now they are coming back with fevers and increased white blood cell count, they've developed pyonephrosis. Not uncommon to see this in kids. The way that the kidney is built can also make a person more susceptible to developing pyonephrosis. Another thing that pyonephrosis can lead to then is the renal carbuncle or renal abscess, where a pocket of pus has been kind of blocked off by the organ and it becomes an abscess. So these pictures here are probably a little bit more of renal carbuncles or renal abscesses because they are kind of focal in in the section that they're in. You'll notice in get my laser pointer up here. You'll notice in this section here, this is kind of that renal abscess area. Then we have a pocket of low-level echoes that's representing the pus. With color on, we're only getting color into the rest of the kidney. We are not getting anything in the abscess, and that's pretty typical of abscesses. We get color around, not in. The CT then also shows a pocket focal area of pus. Pyonephrosis can just refer to having pus within the collecting system, within the calyces of the kidney as well. But then again, those can block off and become abscesses or carbuncles. Emphysematous Pyelonephritis is another variant of infections that we can get in the kidneys, and this is quite often caused by E. coli. So when a patient has a UTI caused by E. coli, that E. coli can travel up the ureter and settle in the kidney. If that happens, the bacteria are going to produce air as a side effect, and when that air is produced within the kidney, that's where we get the emphysematous part of this. There's air in the kidney. This is, again, another emergency. We need to get this kidney out of that person. If the kidney were to stay in there, the bacteria could rupture walls, and then the bacteria can get into the blood system very easily. So it's very concerning when a patient has emphysematous pyelonephritis. Because the kidney in itself is infected, we're going to see increased blood flow because it's inflamed, but there might also be areas of no blood flow. And in those areas are typically then where we're going to see that air. So here we have a normal kidney. All of this area is very, very inflamed. This area here is the area that's not not lighting up when we put color on. Because of that, then we can see kind of some heterogeneity in here. We see this like little echogenic area here. That's going to be probably a little air bubble. So same idea. So there should be some ring down behind some echogenic air bubbles within the kidney. Xanthogranulomatous Pyelonephritis. We've heard that word before, and we've heard it with the gallbladder. And it's kind of the same idea. What happens with the xanthogranulomatous portion of things is that something that's just been infected and has stones in it, like the gallbladder or the kidney, it just is chronic obstruction, chronic infection, and what ends up happening is all these like white blood cells and all these little fighters in the body come to that organ and they try to fight off all these constant attacks. And eventually it all just kind of gets stuck in there. And so what happens then with Xanthogranulomatous, all these histocytes kind of get stuck within the fat, the lipids of the kidney, and it starts to make the kidney not function very well because it's just, there's too much stuff in there and the kidney just doesn't know what to do with it. So a person with Xanthogranulomatous Pyelonephritis is most likely going to have a history of multiple infections. They might have a history of Staghorn calculi, or they're going to have some abnormal lab values that are showing that their kidneys aren't functioning very well. So here's an image of that Xanthogranulomatous Pyelonephritis. The appearance of this is going to be different for everyone. It kind of depends on what stage they're at with it. If they have a Staghorn calculus, we're going to see this really bright echogenic area right through the pelvis here. That is the Staghorn calculus. It is a large stone that's completely filling the pelvis of the kidney. We might also start to see some fibrotic changes to the kidney. So that's kind of these white dashes that are coming out here. Those are, the kidney has been trying to heal itself. It's just part of the constant infections and then healing process. There might also be some cystic spaces. We can see those here, typically out towards the cortical medullary border. In general, the whole kidney will be a little bit larger, and we can see this in segments, or it can be the whole kidney. Nephrocalcinosis is another condition that can occur. We talked about this earlier. It has a very similar appearance to acute tubular necrosis. So it kind of depends. Is there some sort of insult to the kidney that would be causing this renal failure or the acute tubular necrosis? Or is there some sort of infection going on, and does that lead us more to nephrocalcinosis? There are two different subtypes of nephrocalcinosis. We can have parenchymal calcifications, or we can have pyramid calcifications. So typically with the parenchymal calcifications, they're going to affect both kidneys, because again, this is an infection that's kind of going on through the body. And then there's going to be calcium deposits that are abnormally left in the kidney because of this infection. When a patient has cortical nephrocalcinosis, so that's going to be where the cortex is a little bit more affected rather than the pyramids. We see that quite often with that glomerulonephritis. If the patient just has excessive calcium in their blood, hypercalcemia. Sickle cell patients, and then patients who are rejecting their transplant are quite commonly going to have the cortical version of this nephrocalcinosis. So here's an example of cortical nephrocalcinosis. Remember, the cortical part refers to the cortex. So we have very, very echogenic cortex out here with relatively normal pyramids. Again, there's calcium deposits that are being left out in that cortex, making it look very bright. The other kind that we talked about then is the kind that affects the pyramid. So this is medullary nephrocalcinosis. And now the cortex is relatively normal, but what we're seeing are very bright pyramids. Again, calcium deposits within the pyramids. And that brings us to the end of our renal infections. Our next subsection will be renal vascular pathology.